Good day, everyone. We are the Group 4 and we will be reporting about the prostatic problems and erectile dysfunction. So, do you have any idea what is prostatic problems? How about erectile dysfunction? I'm sure you've heard about this. So, basically, prostatic problems are conditions that affect the function of the prostate and causes pain and discomfort. So, there are three conditions under this. First, the prostatitis. It is the inflammation of the prostate. Second, the prostate cancer, where cancerous cells grows in the prostate. And lastly, the BPH or the benign prostatic hyperplasia, where the prostate grows larger without the cancerous tumor. So, we're done with the prostate problems. We move on to the erectile dysfunction. Erectile dysfunction is where men can't get erect or get their penis up. Based on studies, in younger men, erectile dysfunction is usually caused by psychological problems, while in older men, erectile dysfunction is caused by blocked blood flow to the penis, and it is also caused by hormonal imbalances. So, because of erectile dysfunction, sometimes it causes couples to feel confused, anxious, and undesirable.
This is the pathophysiology of erectile dysfunction. So before we dive into the pathophysiology, let me first describe what is erectile dysfunction or ED. ED is a condition characterized by the persistent inability to achieve or maintain an erection sufficient for satisfactory sexual performance. It can have multiple underlying causes and can be a result of complex interactions between psychological, hormonal, and vascular factors. As you can see, it is divided into two parts. The first one is organic erectile dysfunction, and the next one is the psychogenic erectile dysfunction. So let us first um, discuss organic erectile dysfunction. Organic erectile dysfunction is gradual, all circumstances, older, nocturnal, or AM erection absent. So as you can see, it is divided into three parts. The vascular factors. The process of achieving an erection involves a complex interplay between the nervous, vascular, and endocrine systems. Any disruption in this process can lead to ED. Vascular factors play a significant role in ED, as the penile arteries need to dilate and allow increased blood flow to achieve an erection. Conditions that impair blood flow, such as atherosclerosis or the narrowing of blood vessels, or endothelial dysfunction, which is the damage to the inner lining of blood vessels. All this can contribute to ED. As you can see, we have here the signs and symptoms or the lab findings. First is to assess CVD disease risk. It is divided into three parts: increase in blood pressure, increase fasting glucose of HbA1c, increase in TGs and cholesterol. And then we have here penile duplex sonography or the cavernosometry. Next one is the endocrinologic erectile dysfunction or the hormonal factors. Hormones play an essential role in regulating sexual function. Testosterone, the primary male sex hormone, is necessary for normal erectile function. Low testosterone levels can contribute to ED, and other hormonal imbalances such as thyroid disorders or abnormalities in the hypothalamic pituitary gonadal axis can also contribute to erectile dysfunction. So as you can see, we have here the signs and symptoms again. We have here the decreased 7 a.m. free testosterone, increase in thyroid stimulating hormone, increased prolactin, increased follicle stimulating hormone, increase in luteinizing hormone. And for the last one, we have here the neurogenic erectile dysfunction. So the neurogenic factors or the nervous system plays a vital role in initiating and maintaining an erection. Neurogenic causes of ED can include conditions such as spinal cord injury, multiple sclerosis, Parkinson's disease, or damage to nerves due to surgery or trauma. Dysfunction in the neural pathways involved in penile erection can lead to impaired sexual function. So for the other part of the ED, which is the psychogenic erectile dysfunction, it is sudden onset, sporadic, younger, nocturnal, or AM erection present. So for the psychological factors such as anxiety, depression, stress, or relationship problems, all can impact sexual function. These psychological factors can lead to performance anxiety, reduced sexual desire, or difficulties with arousal resulting in ED. As you can see here, we have the signs and symptoms, which is the normal nocturnal, penile, tumescence, and rigidity. All these factors lead to the decreased release of nitric oxide, and as we all know, nitric oxide is responsible for vascular tone and blood flow. And as the release of nitric oxide decreases, it leads to the narrowing of blood vessels, or as I've said earlier, atherosclerosis. And if there's also decrease of CGMP, or cyclic guanosine monophosphate, um, we all know that CGMP is a second messenger molecule formed in different cell types and tissues, and it targets a variety of downstream effector molecules and thus elicits a very broad variety of cellular effects. So if there is decrease of both nitric oxide and CGMP levels within corpora cavernosa and smooth muscle relaxation, this leads to erectile dysfunction. It is important to note that the pathophysiology of ED is multifactorial, and often multiple factors can contribute simultaneously to the development of the condition. So I think that's it for the pathophysiology of erectile dysfunction.
Then let's move on for the pathophysiology of the prostate problems. But first, I want to give a brief overview of the prostate. So the prostate is roughly 3 centimeters long, about the size of a walnut, and weighs approximately 20 grams. Its function is to produce about a third of the total seminal fluid. The prostate gland is located in the male pelvis at the base of the penis. It is below or inferior to the urinary bladder and immediately anterior to the rectum. The prostate is primarily glandular tissue which produces fluid that constitutes about 25% to 30% of the semen. This prostatic portion of the semen nourishes the sperm and provides alkalinity, which helps maintain a high pH, or the seminal vesicle produce the rest of the seminal fluid. The prostate gland requires androgen or testosterone to function optimally. This is why hormonal therapy or testosterone deprivation is so effective. Then let's move on to the pathophysiology of the prostate cancer. So the prostate cancer is an adenocarcinoma as it develops primarily from the glandular part of the organ and shows typical glandular patterns on the microscopic examination. Also, in the prostate cancer, there are modifiable and non-modifiable risk factors associated with prostate cancer. These are the gender, age, and genetics for modifiable risk factor, and lifestyle, vasectomy, and multiple partners for non-modifiable risk factors. If the cancer cell grows and begin to multiply, initially spreading to the immediate surroundings prostate tissue and forming a tumor nodule. Such a tumor may grow outside the prostate or extracapsular extension or may remain localized within the prostate for decades. When the cancer cells begins to multiply and spread, doon nagkakaroon ng formation of tumor or nagko-cause ng enlargement of tumor in the prostate gland. Because of the enlargement of tumor, nagko-cause naman ito ng constriction of urethra kaya nagkakaroon ng dysuria, dribbling, pain, polyuria, and hematuria. And because of the enlargement of tumor in the prostate gland, doon nangyayari ang invasion of nearby organs. That's why in the rectum, nagkakaroon ng pain and blood in stool. As well as in the seminal vesicles, there are pain when ejaculating and hematospermia. And also when the cancer cells continue to multiply, it causes prostate cancer to advance and cancer cells metastasis in other parts of the organ through lymph and bladder, but prostate commonly metastasizes to the bones and lymph nodes.
Here are the clinical manifestations where you can identify that a person has prostate problems. First is frequent urge to urinate or urgency in urination. Second is blood in urine or semen. The third one is pain or burning sensation during urination or ejection. Fourth is dribbling of urine. Fifth is difficulty starting or stopping urinating. Then lastly is frequent pain or stiffness in lower back, hips, pelvis, upper thighs, or rectal area.
Erectile dysfunction, clinical manifestation, trouble getting an erection, trouble keeping an erection, and reduced sexual desire.
Okay, so we have here different laboratory tests which is used to diagnose the disease. So for some men with erectile dysfunction, specialized testing may be needed to guide the treatment or assess after the patient's treatment fails. So first is a blood work which is used to check testosterone and other male hormones, also used to measure the blood sugar of the patient. An ultrasonography also through a penile Doppler used to check the blood flow. And a shot into the penis with a vascular stimulant may be used to cause an erection. And for pelvic x-rays like arteriography, MRI, or CT scanning are rarely needed to check erectile dysfunction unless the patient has a history of trauma or cancer. And a nocturnal penile tumescence or NPT, which is an overnight test used to check for sleep erection. And the healthcare provider will likely start by asking the patient's symptoms, and then he will get a physical exam. This includes digital rectal exam. A digital rectal exam is a procedure in which the healthcare provider inserts a finger into the patient's rectum to check if his prostate is enlarged. Also, a urine test in which it checks the patient's sample of urine to find out if he has an illness or other problems that can cause the same symptoms as of those benign prostatic hyperplasia or the enlargement of the prostate gland. Also, another is a blood test again, in which this can show if the patient's kidney has problems. And after that, the patient might need other tests that can help confirm an enlarged prostate. These tests include prostate-specific antigen or PSA blood test. PSA is a protein made in the prostate. The levels of it goes up when the prostate becomes enlarged. But higher PSA levels also can be due to recent procedure, illnesses, surgery, or prostate cancer. And also another test is a urinary flow test, which the patient pee into a container attached to a machine, and then the machine will measure how strong the patient's urine flow is and how much his urine passed. And the test results of this can show over time whether the condition is getting better or worse. Also, another test is a post-void residual volume test. This test measures the patient whether he can empty his bladder fully. The test can also be done using an imaging exam called ultrasound. And if the patient's health problem is more complex, he maybe need tests like transrectal ultrasound. Transrectal ultrasound is a procedure wherein a device that uses sound waves to make pictures is inserted into his rectum. It measures and checks the prostate. Also, a prostate biopsy test in which a transrectal ultrasound guides needles that are used to take tissue samples of the prostate. Checking the tissue can help the provider find out if the patient has prostate cancer. Also, urodynamic and pressure flow studies can be used, in which a catheter is threaded through the urethra into the bladder. Water or less often air is slowly sent into the bladder to measure the patient's bladder pressure and check how well the bladder muscles work. Another test is a cystoscopy, in which a lighted, flexible tool is placed into the patient's urethra. It lets the provider see inside the urethra and bladder. But before this test, the patient may be given a medicine that will keep him from feeling pain.
So let's proceed to the nursing management and intervention. Number 1, the patient education. We provide education about the cause of erectile dysfunction, the risk factors, and the treatment options. We encourage the patient to have a healthy lifestyle, including maintaining a balanced diet and regular exercises. Next one, Medication management. We assess the patient to have a medication management, including explaining how to take the prescribed medications such as phosphodiesterase 5 inhibitors and their potential side effects. Third one is emotional support. We offer emotional support and create a safe space for the patient to discuss their concerns and feelings related to the erectile dysfunction. We address any psychological factors like anxiety or depression that may contribute to the condition. Fourth one is support for partners. We offer support to the patient's partner as ED can affect both individuals in a relationship. We encourage open communication and consider counseling or therapy if needed. Next is lifestyle modification. We encourage the patient to make healthy lifestyle changes such as smoking cessation, reducing alcohol consumptions, and managing stress. Another intervention is referral. We collaborate with other healthcare professionals like urologists or mental health specialists when necessary for a comprehensive approach to the ED treatment. Next is assistive devices. We provide information on the support for the use of vacuum erection devices or penile implants if appropriate. Lastly is we monitor adherence. We ensure that the patient is adhering to the prescribed treatment plan and follow up regularly to assess progress and make necessary adjustments.
For the physical treatment, phosphodiesterase type 5 inhibitors. Phosphodiesterase type 5 inhibitors are indicated for patients with erectile dysfunction. The medications increases blood flow to the corpus cavernosum by relaxing smooth muscles. The examples of PDE5 inhibitors include sildenafil, tadalafil, vardenafil, and avanafil. Since they are both cause significant hypotension, avoid concurrent administration of PDE5 inhibitors with nitrate drugs. So these phosphodiesterase type 5 inhibitors increases blood flow to the penis and improve erectile function. For vacuum constriction devices pull blood into the corporeal body to produce an erection. Examples of vacuum constriction devices that retain venous blood for maintaining an erection include a penile ring or constrictive band. So, physicians commonly use vacuum constriction devices to treat poor blood flow into the penis and excess blood flow out of the penis during erection. So, this can help men to achieve or maintain an erection. Intrauretral devices. In combination with vasoactive drugs, intrauretral devices enhance blood flow into the penile arteries. Vasoactive medications are administered as a topical gel, intracavernosal self-injection, or insertion of a pellet into the urethra using a medicated urethral system for erection devices. Examples of vasoactive medications include papaverine, alprostadil, and pentolamine. So, this is a medication that treat ED by increasing blood flow to the penis to achieve and maintain erection. Penile implants. These surgical procedures are highly invasive and may cause complications. Penile implants are indicated for patients experiencing erectile dysfunction. Complications related to penile implants include mechanical failure, infection, and erosion. Semi-rigid or inflatable penile prostheses are implanted into the corporeal bodies to sustain an erection firm enough for intercourse. So, penile implants is a short procedure that requires minimal downtime, and many of them are able to return to their usual routine after a week and can resume sexual activity after 6 weeks. So, unlike other ED treatments, they can achieve fast resulting using a penile implant that won't interfere with intimate moment. It also provides reliable results for 10 years longer. So that's all that we got about the prostate problems and erectile dysfunction. Thank you for listening and God bless us all. Thank you.